Welcome back. Now, reliance on last resort antibiotics is rapidly increasing, and this is according to research conducted by the University of KwaZulu-Natal and Nesta Challenges Longitude Prize. Now, the research also examined the 5-year trend of drug-resistant infections. And to help us unpack what all of this means and the research that was conducted, we joined via Zoom now by Daniel Berman, who is Director of Global Health at Nesta Challenges. Daniel, thanks so much for your time. Welcome to Morning Live.
Thank you for inviting me. I really appreciate this chance to speak to you and your viewers.
So let's just start first with your paper, your research, and what it's about. If we could just take a quick look at a synopsis of this.
Okay, I think if you don't mind, I'd like to start even a little bit higher level. Just kind of answering the question why your viewers should care, or why this, what is the issue that we're talking about. First off, I want to mention is that the research that we published last week in Lancet Global Health was co-authored by myself, but most of the work in South Africa was done by Professor Sabia. And I just wanted to be clear that she is South African Research Chair in antibiotic resistance, and she's at University of KwaZulu-Natal, plus she's an advisor for the World Health Organization. So she's really passionate, and I think that's where partly this work came from. So she came from the perspective of she's worried about how antibiotics are being used and wanted to actually dig down and find out what the statistics said. And I came at this from the place of we run a challenge prize. It's an international competition to come up with a new diagnostic tool to better use antibiotics. And so I noticed and I understood from diagnostic makers how incredibly difficult it is to actually get these tests into hospitals and clinics. I'll just give you one example before I go into the details of the study of what it means to people in the day-to-day life. So we were looking at resistance to antibiotics, infections in things like bloodstream infections. So those are the most dangerous infections that really can be life-threatening. So imagine you have a urinary tract infection and it becomes severe. What if the antibiotic that you take doesn't work anymore? And that's what really the crux of the matter. I'll just give you one other example. We looked at Klebsiella pneumonia, a very serious type of pneumonia. And what happens there is you can only imagine if you have a serious pneumonia in your lungs and the antibiotics that you're given the first time don't work or the second time. So let you jump in and ask another question before I go on.
So I was going to ask, as you're explaining, of course, in terms of the research that was conducted, what were some of the more salient findings?
Okay, I will tell you that. The first thing to do is say it was looking at 5 years of data. And this is the amazing thing that Professor Essek did, because she got data from the NCID, who I know you're talking a lot about in terms of COVID. And so we're talking about national data and looking across all 9 provinces. And she got access to data from one of the biggest labs. So that was looking at how the resistance was changing over a 5-year period. And so what we found was that there were 2 antibiotics. This is just an example. We have a lot of examples. So, for example, I mentioned pneumonia. And the level of resistance is gone up 200, in one case of one antibiotic, 300% over 5 years. This is really worrying because the WHO talks about 3 categories of antibiotics: access, watch, and reserve. So access are the ones that we should be using and they're available. Watch you should be using very, very sparingly. And the bottom line here is that we are tapping into the absolute last resort of antibiotics called reserve antibiotics. And another statistic that we published in the paper is that there was a 650% increase in some of the most important reserve antibiotics. So now that data was actual purchase across all 9 provinces of antibiotics. So that came from the Department of Health. So we see this very significant rise in use of reserve antibiotics. And when those are not there anymore, that means there's nothing and there's no choice. So antibiotics are really a building block of so many things that we do in medicine. And so it's really a worrying trend.
It certainly is. Were you able to ascertain what some of the reasons were behind these increases, Daniel?
Yes, definitely. So one of the issues is we refer to stewardship. So it means that since it's difficult to know what exactly bug a person has, what bacteria, and also which bacteria will work. For example, today's diagnostic tests, take 2 or 3 days. So by then, it's too late. So what a lot of physicians are forced to do, they're not doing the wrong thing, is because they don't have tests that precisely tell them what's the resistant level of an antibiotic and which exactly infection they're dealing with. They have to throw a lot of antibiotics at the patients when they're worried that they're getting, for example, severe bloodstream infections. So better diagnostics is an answer, and more availability of the drugs, because one of the big issues is these reserve drugs are in South Africa. Some of them are not registered, some of them are not available because it's a really small market, which is kind of a good transition to, okay, what can we do about this? And for the last 2 years, we've been exploring. It's funny to relate it to something so far from medicine, but basically we're promoting a Netflix model in terms of buying these reserve and watch antibiotics, and also the new ones that will come up. So what does Netflix model mean in terms of antibiotics? It means instead of paying for each pill, the contracts would be written by the Department of Health for large groups of patients, and you'd pay so much whether you use the drugs or not. And why does that make sense? Because these these watch and reserve antibiotics, what you really want to do is use them as sparingly as possible. So if we change the model and we have contracts with companies and they're selling and they're getting the same amount of money no matter how much antibiotics they sell, it would be a way to get a steady supply. So in every hospital in South Africa, doctors would know that all of the potential antibiotics, so they could use the one that was best indicated. And then another idea is to pool the demand, so to create a kind of procurement mechanism. It's not so different from the way that ARVs for AIDS are antiretroviral drugs are so well organized in South Africa. So what we're saying, if you can do that for AIDS, and so many people depend on the government supply, and it works actually really well, we have to think about doing a similar system for antibiotics. Because if we run out, then we're kind of back to the dark ages in terms of modern medicine.
And Daniel, the fact that we've been in the grips of a pandemic, a global pandemic, over the last 2 years, did that have any sort of impact on the uptake, the increased number of last resort or reserve antibiotics?
Okay, so that's definitely a mixed picture, because what experts are saying is that in some cases, patients come into hospital and they're quite sick, and so they're given antibiotics, which don't, in 9 out of 10 cases, don't do anything, because obviously COVID is a viral infection, not a bacterial infection. So there was some increased use at the beginning, but overall, because people have less access to healthcare, in the last couple of years, we have seen overall general use of antibiotics in the public going down. But we know that this is a temporary trend. But one thing I think might be interesting for viewers is, well, what can you do, right? How can you impact this? One thing is, think of antibiotics as a precious resource. So if you have a sore throat, you're probably going to get better without taking antibiotics. And if it has a viral cause, antibiotics won't make any difference. So don't use antibiotics unless a doctor advises you to. Don't use extra pills that are lying around because somebody didn't finish their course. So I think each of us can really make a difference by just thinking about, wait a minute, this is something that I've taken so many times in my life, but now that the resistance is rising so significantly, and the resistance of taking the wrong antibiotic for a simple urinary tract infection can lead to E. coli in hospital, which sometimes causes urinary tract infection, to be resistant for something that's a lot more serious. So we're all in the same boat here. And I think also in private and public sector in South Africa, we see very serious overuse of antibiotics in the private sector. Of course, you can guess, right, that they have more access to expensive antibiotics. That's not necessary. In this case, that you're not necessarily better off, right? If as an individual, you've taken too many antibiotics or you're taking the newest, most expensive antibiotics. It doesn't work like that. And the public sector, people who get their health care, 80% of people in the public sector and people in the private sector, we're in the same boat. So it's really critical that government, this is not the moment, let's be realistic. Now is the moment to deal with COVID. But it's the time to plan, because in a couple of years from now, over the 5-year trend showed significant rise in resistance over that 5 years. So what we're really worried about is if we don't dramatically change how we use antibiotics, and if we don't start getting a lot more precise diagnostics so we know about resistance in actual individual patients quickly, then we're going to lose antibiotics, and it's going to be a worse crisis even than COVID, because it's not going to go away.
So just in conclusion, what would you recommend? Is it a regulatory issue? How do we then stem this access to antibiotics, especially when it's not necessary?
Yeah, I mean, I guess I would divide it into two different categories. For individual people, as I said, if you get a prescription for antibiotics, really ask your doctor why, and it's up to all of us to kind of understand and to, as I said, limit our personal use to only when they're necessary. But then from a policy level, we actually need, it sounds a bit counterintuitive because I said we want to discourage overuse, but more importantly, we need to have a portfolio of antibiotics and diagnostics which are available in all hospitals. And I can tell you, ARVs are there in the system, but these watch and reserve antibiotics are not available evenly. And so we think from a policy perspective, there needs to be a procurement, a purchasing system. So they're all available, and that in addition to supporting, educating physicians about stewardship, how to use antibiotics, and just helping them in terms of this specific issue, the supply is really important. So we're really looking forward to a deeper exploration to create this Netflix model or subscription model for antibiotics and for diagnostics.
Well, Daniel, thanks so much for your time and for speaking to us this morning. And that was Daniel Berman, and he's Director of Global Health and Disability at Nesta Challenges, speaking to us about new data which shows that a reliance on last resort or reserve antibiotics is rapidly increasing among South Africans, and also speaking to what some of the recommendations may be in trying to stem that particular tide. Well, that's what we are going to have to park it for this morning. And of course, Leanne, we're going to take a break first. Oh, what's the time? Okay, we still have time for a short break before we say goodbye. So let's take that break quickly.